Morning, everybody. Welcome to our second annual APLC Summit. Those of you who joined us in Bangkok last year, welcome back. And those of you who are joining us for the first time, welcome. We have some new members who have joined us, and then we have, of course, some guests that are here. In particular, I want to acknowledge our 10 local representatives from Chiang Mai uh, as our guests. Can we have a show of hand where you are? The local, right? Welcome everybody. Thank you. Okay. So this is like a start of a new trend. We will be moving forward, inviting local participants to join us wherever we are. So this is very good. So welcome and make yourself at home. Okay. And we have a very exciting program for you lined up next 2 days. And without further ado, I want to introduce you to the very hardworking President Supon to actually welcome you officially. Thank you.
Good morning, everyone. My name is Dr. Supon Jancharuni. I work at Ramathibodi Hospital, Bangkok, Thailand. And on the behalf of the Thai Organizing Committee, we are delighted to welcome you to the second Asia Pacific Leukemia Consortium. This is now in Chiang Mai. Chiang Mai is known for its rich culture and history as the capital of Lanna Kingdom over 7 centuries. Chiang Mai has developed a very distinctive culture with wonderful traditions. You will hear more from our coordinators, co-organizers, Dr. Lalita and Dr. Adesak, who will be the next speakers. The goal of the meeting is to bring together the experts in the field of leukemia and related disorders for sharing our knowledge, experience on treatment, and identification of common challenges in the APAC regions. The program is packed with keynote lectures, workshops, and panel discussions. We have invited the well-known experts and speakers to share their expertise and perspectives. I would like to extend our sincere gratitude to our speakers, moderators, and panelists, and of course, your attendance. I also would like to thank my coordinators, Dr. Lalita Noraset Thada and Dr. Adisak Tantiwalawit, who arranged uh, this meeting perfectly. Both of them are in Chiang Mai, so they know Chiang Mai much better than me, and you will hear more about Chiang Mai from them. We would also express our heartfelt thank you to our pharmaceutical partners and sponsors, platinum, gold, silver, and bronze, for their great continuous support and contributions. And of course, I would like to thank Lynn, who worked closely with Dr. Go for her great effort behind the meeting arrangement. Finally, I would like to express my sincere hope that your contribution to this symposium will make it fruitful and will be achieve the objectives for which it is was organized. Next, I would like to invite my co-organizers, Dr. Lelita Norsethada and Dr. Adesak Tantil to deliver their speech as well. Please come to the podium. Thank you very much.
Okay. สวัสดีค่ะ and good morning, distinguished speakers, colleagues from across Asia Pacific and and well, the second. Yeah. Welcome everyone to the second in Chiang Mai, Thailand. And Chiang Mai is our Chiang Mai is our hometown, and where at the Chiang Mai University Hospital. And Dr. Supon already mentions Chiang Mai have a rich history over 700 years. It used to be the capital of the Lana Kingdom in the northern part of the country. We have our own cultures, own local language and food that some of you have been have tried last night. And it's our honor to have you here with us today as we have a same missions uh, to improve the treatments, management, and the outcome of patients with leukemia across the regions. Okay, I'm here with my colleagues, Professor.
Hello, hi, good morning, everyone. Welcome you all to Chiang Mai. I think Dr. Ta will briefly show that how our today agenda will be for the APLC meeting, the second one. Dr. Lina, please.
Okay, so we have a whole the 2 days agendas that has been comprehensive arranged, and it would we will go through all aspects of leukemia, and we hope that all the agendas which is a well designed to foster the knowledge, new emerging trends, and hope we can exchange our knowledge and as well as collaborations across our groups. And after the sessions in leukemia, we're gonna have the breakout sessions.
Yeah. In this afternoon, we're gonna have 3 breakout sessions: the acute myeloid leukemia, the ALL, acute lymphoblastic leukemia, and the CLL, and it's already shown in the group. The AML this afternoon will be in this room, but the ALL and the CLL will be on the third floor that we have the where we have the dinner last night. If you want to know where you are in the group, you just see the badge. On the lower, it show you which group that you're in the batch. It's a working group, and like me, I am in the ALL. I think this afternoon before the break, we will show this side again, and we will go to the breaking room for your group. Thank you.
Right, and there's some housekeeping rules, like a general one, just to remind you on that. And uh, after all, we got dinner tonight, and I would like to invite everyone to join us. The please meeting point is at the hotel lobby at 6 p.m. It's the offsite dinner in another part of the city. So during the transportations there, you can see like doing sightseeing our OCD. You will see our intact OCD gates during the time that we are going to the dinner place. Have you been there?
Yeah, I went to it once. It's quite homey restaurant
Right.
that you stay in the home and it's Thai food.
Right.
Yeah, it's very
And
good.
pretty cozy and like homey style, so you can catch up with the colleagues, and if you still have furthermore discussions and haven't done that during the meeting, you can do that, so or catch up with friends and colleagues during dinner time. And it's a very at that place we have a very nice Thai cuisine, and so you can enjoy that. Okay, 6 p.m. at the lobby. And for next, I would like to uh, extend my our gratitude to our sponsor and the industrial partners for supporting us. Your supports have been instrumental in making these events possible. Let's watch a video recognizing our sponsor. So I would like to thank you all of you for coming here today, and I hope you have fruitful meetings and collaborations.
Yeah. Let me hand on to our next session. So it's going to be the first plenary session in acute myeloid leukemia. Let me introduce the co-chair of this session. The first one is Professor Hu Shin An. Yes. The second co-chair is Professor Lau Sen Tang. And the third one, he will join us virtually, is Professor Andrew Wei. Everyone, please welcome our co-chair for the session, AML, please.
Hi, everyone. Thank you for attending the APLC plenary session. So today, I think we will just kick off with our distinguished speaker, Mark Levis. Mark Levis is... no, he's...
Hello, everyone. First, I would like to briefly introduce our distinguished guest, Professor Mark Levis. Professor Mark Levis is a professor of oncology medicine and pharmacology in the Division of Hematology Malignancy in Johns Hopkins University School of Medicine. Co-directs the hematology malignancy and the bone marrow transplantation program, and directs the adult leukemia service and the Johns Hopkins Sydney Chemo Cancer Center. In addition to his role within the Chemo Cancer Center, he serves on the faculty for the Johns Hopkins graduate training program in cellular and molecular medicine, a PhD program that prepares scientists to conduct laboratory research at the cellular and the molecular level that is designed to have a direct impact on the University of Human Disease. Professor Davis has expertise in acute and chronic myeloid leukemia, acute lymphoblastic leukemia, and myelodysplastic syndrome. He received his medical degree at the University of California, San Francisco School of Medicine, where he also earned his PhD degree in biochemistry. I think everyone are aware he has done a lot of very important translational research, especially in acute myeloid leukemia. I think it's our great honor that Professor Davis could be here to give a talk. Professor Davis, please.
I want to start by thanking organizers of this meeting. I'm delighted to be here in Chiang Mai. This is my first visit here. Looking forward to this meeting. Okay, so I was asked this question: do we have the tools to cure FLT3 mutant AML? How do we maximize our chances of doing so? So what I am going to share with you today are the tools that I have. And the tools that I think are rapidly being made available around the world. And so I will go over those tools, and in part, they're my financial disclosures. But the question that I'm given, I frequently get asked by people from around the world, how do I manage this case? What do I do? Given a patient or whatever and ask for advice. And this is not a simple question, for as clinicians in the audience know, management of FLT3 mutated AML. Well, which patient are we talking about? Is it young, fit patient? An older patient? Sometimes older patients come in and they look terrible because they have leukemia, and you put them in remission quickly and now they look much better. Maybe our approach is going to be different. So what I'm going to do is focus first on the disease. We think of FLT3 as, or AML as arising out of a series of mutations in stem progenitor cells, a founder and a cooperating mutation, and then a signaling mutation. But FLT3 mutant AML is not one disease. There are many different versions of it. For example, this particular one, this triplet, Yvonne pointed this out to me as the terrible triplet some years ago. And the NMT3A, NPM1, FLT3 mutation. Okay, this is one version. Well, shown on the left here, there we go. Shown here, if you just treat this disease with chemotherapy, triple mutation, they do quite poorly. Whereas in the relapse setting, very curiously, patients with this triple combination did remarkably well with gilteritinib. We actually saw a plateau in survival. We never see that in relapsed disease. Here are data from my own institution just in the last 3 years. The triple mutation looks like APL. We're having no trouble with it at all, using very heavy use of FLT3 inhibitors. So, and yet, you see the patients without the triple mutation are the ones I'm having more of a challenge with. It's not one disease. In fact, looking over, again, the last few years at my institution, every AML patient that comes in, we have many different subtypes of AML. I'm busy trying to convince the transplanters that I work with that AML is not one disease. There is this dreadful entity, TP53 complex karyotype. I know you see this. I've never really seen this reliably cured. FLT3 doesn't occur in that subset of AML at all, really, or not meaningfully. Core binding factor, it's quite common. We were talking about this last night, FLT3 mutant AML. Different impact on the disease. APL, FLT3 mutations are very common. They make it more exciting, but you can cure them pretty much. Myeloproliferative neoplasms, you will see them occasionally have a FLT3 mutation. MDS will occasionally get a FLT3 mutation as it transforms. Then finally, I think the entity that we all think of is really still only a fraction of all FLT3 mutant AML. This, in fact, the triplets would be found in there as well. So we're going to talk about the tools that we have. I'm going to share with you some recent data from a randomized trial that really impacts how I manage my patients. And I'm going to present to you some patient cases that I'm managing right now and see how I am using the tools that we have. So what tools do we have? Well, PCR. Now you think of this as an old tool, but it's still an extremely useful tool. You can get a lot of information out of it. But in particular with FLT3 ITD AML, remember, so this is a PCR reaction. You put the primers flanking the region of interest, and you go back and forth with PCR. But this, the mutant version with the insertion, is longer, is less efficiently amplified. So if you take a pure population of leukemia and put it into a PCR reaction, you don't get equal peaks because this is amplified more efficiently. And if you try to make the PCR more sensitive and do more cycles of PCR, you only make this worse. The wild type outcompetes the mutant. This is called template bias, and it means the PCR assay is at best 1% sensitive. That's a microscope as far as I'm concerned. I can spot leukemia at that level with a microscope. So that's not very useful, but you can learn a lot from PCR. Length, for example. I would always stress the importance of knowing the length of the mutation that you're dealing with. We know that a longer mutation is worse. It also, as I've just shown you, impacts your ability to even detect it. A 90 base pair insertion is actually very difficult to pick up by PCR because it's so inefficiently amplified. You'll see a VAF in such a long insertion artificially low. But the length matters too. We've seen in study after study, the longer ITDs are worse. And in fact, fast forward to today, these are data we presented at ASH. Even in Quantum First, the study of quizartinib plus chemotherapy or chemotherapy plus placebo, longer ITDs did worse. Fortunately, quizartinib was effective in either one. Going back 20 years, here's what you can do with PCR. This is work out of the UK. Using PCR, we found that the more mutant that you showed up with that diagnosis, the worse you did. So high VAF or allelic ratio was worse outcome. An NPM1 co-mutation identified by PCR, better outcome. ITD length, clear back 20 years ago this was known, and then something I'll touch on at the end, multiple mutations. This is a new thing, and multiple mutations are bad, I will tell you that. So that's one tool, PCR. Another tool, of course, FLT3 inhibitors. There's lots of FLT3 inhibitors running around the world right now. There's 4 of them that are in use worldwide somewhere for various indications. And they're different. Type 1, which hits both TKD and ITD, and type 2, which only hits the ITD mutation, but perhaps is more potent and selective. We have chemotherapy, our old friend. When we combine it with a FLT3 inhibitor, we improve survival. We have allogeneic transplant, very popular. And in fact, the general consensus is a patient with a FLT3 ITD mutation, when feasible, should be offered allogeneic transplant. And after the transplant, we can offer them a FLT3 inhibitor as maintenance. And again, which one you choose depends on which one you have. Sorafenib, I think, is been most widely around the world, but sorafenib is very difficult to tolerate, and there are alternatives coming up I think are going to become more popular. Very important new tool is this one, AZA-VEN. We all know AZA-VEN, how it has changed the field. We actually are using AZA-VEN in all AML patients at my institution 60% of the time, relative to only about 40% with intensive induction like 7 and 3. And interestingly, I again just looked at the outcomes for the last 3 years at my institution for FLT3 ITD AML, and whether they were induced with AZA-VEN or intensive, it didn't seem to matter. I think the field is going to dramatically change with the availability of this as we think about how we treat these patients. The problem with AZA-VEN is if you keep giving it to a FLT3 ITD patient or a FLT3 mutant patient, they're going to relapse sooner. In fact, the only main benefit of AZA-VEN in the FLT3 mutant population looks like it's really in the TKD. The ITD patients don't really benefit from AZA-VEN. And yet I just showed you induction, maybe they're doing okay. Point here is you can induce and put them in remission with AZA-VEN and move to something else. Now, a very important topic in this field is MRD, right? We can put a patient in remission. I can do it with AZA-VEN, I can do it with 7 and 3 and a FLT3 inhibitor, that's great. And I look in the marrow and it looks normal and the patient is now back on their feet and looking better. And the patient is in remission, a bone marrow in remission is like a calm sea. Very peaceful. But you don't actually know what's beneath the surface. And so there comes the role of MRD. And so we can detect disease at a very shallow level reliably, or at least that has been the case. That's changing now. How do we pick up this deeper disease? The shark swimming deep below. What level is it at? When is it rising? How quickly can we pick it up? So MRD is an important development in the field that's becoming more and more important in managing the disease. Here are recent recommendations out of the ELN defining relapse now as an appearance or rise in MRD of 1 log. And they don't distinguish how you're detecting the MRD. The recognition that patients in remission with a rising MRD are in the midst of relapse, and you can intervene sooner before the outright clinical relapse. And in fact, here in this study out of the UK and Australia, they used NPM1 MRD to actually follow patients who were getting a treatment that worked, venetoclax-based treatment. And they were watching, these patients are going into remission, but they're watching the depth of remission using MRD. When they applied in this study, when they looked at the patients with FLT3 ITD AML, though, it was clear, and not surprisingly, the FLT3 ITD AML patients were not going into remission as easily with this treatment. And part of the problem is they're looking at NPM1 mutant MRD, and they're using an NPM1 directed therapy. So we really want to focus on the target of our FLT3 inhibitors, which is FLT3 ITD MRD. And so to get around that, we did, many groups around the world have worked on developing a FLT3 MRD assay, or FLT3 ITD MRD assay. The way this works is it's a two-step assay. So we're going to do PCR first. And I've just told you that PCR is not that sensitive. You don't want to do too many cycles. We're going to do a limited number of cycles of PCR and create a bunch of amplicons and then do next generation sequencing. And what will be debated in the field is how much DNA goes in, how many cycles of PCR. But this produces a number, and don't mistake it. I've decided I don't like the term sensitivity. And let me explain what I mean. So here's an illustration of how this FLT3 ITD MRD assay works. You put in DNA into a tube, and you want an adequate amount of cells represented. Okay, so we're using approximately 700 nanograms of DNA, which represents about 100,000 cells. We're going to perform PCR using the PCR primers flanking FLT3 and generate a lot of amplicons and then purify that. So now I have a test tube full of amplicons coding for the FLT3 sequence. I'm going to walk that over to my friendly next generation sequencer, and it's going to perform next generation sequencing on this. Now suppose there's 1 million amplicons in here and we detect 3 with an ITD. So that means 3 out of 1 million, or 3 times 10 to the minus 6. That's just a number. That's not 3 cells in 1 million, as what you'll see reported. It's a number. It's like an artificial color. And typically the number we get is no lower than 1 times 10 to the minus 6. So I don't even know how to call that, how sensitive that is. Can it pick up the disease? How well? Here are different, and this technique, by the way, is 10 years old, 15 years old. It was Michael Heuser's lab first tried it in a small number of patients long ago. Here are 4 different studies that have been published using this general platform. And one of the studies uses only 50 nanograms, and you'll find that when you look at the data from this study, it's much less sensitive. And the other ones is 10-fold less sensitive. It's not picking up the same frequency of MRD as the other studies. The other studies, I think, have coalesced into one that I think is going to be the most useful. And this was done, headed by my good friend and colleague Andrew Way, and in the UK and Australia, where they kind of took all the recipes and combined them. So using 500 or 700 nanograms of DNA, and in the case Andrew's group used 10 cycles, we've actually been using 25 cycles. But using the bioinformatics, which are free and online from the Get ITD study, the whole thing, I think, is nicely summarized and can be reproduced in any lab around the world that is familiar with NGS. Not a difficult assay to do. There's nothing magical about it. And it doesn't have to be as expensive. The Americans, we will always choose the most expensive way of doing anything. And that's, in fact, what we're doing. But it doesn't have to be at all, and other groups around the world are showing that. But what you can do with this assay is, here, for example, is a study. We looked at a series of banked samples from patients with FLT3-ITD AML in remission, PCR negative by conventional FLT3 assay. And we applied this assay to these, and in all cases, we detected the ITD, and we noted that patients who had received their induction with a FLT3 inhibitor had a 10-fold lower reduction in their MRD. So we demonstrated, at least in this small retrospective study, the addition of a FLT3 inhibitor lowers the MRD level. Well, Andrew's group looked at pre-transplant MRD and found that patients who were negative in this assay had the best outcome, whereas patients who had a high level, in fact, practically detectable by conventional PCR, had a terrible outcome after transplant. This study out of the HOVON demonstrated that it was the most predictive marker for outcome in FLT3-ITD AML, and in fact, in comparison with multi-parameter flow cytometry, added nothing whatsoever to this study. And this was even more useful than NPM1 MRD. So it's a very powerful assay to use. We looked at it also in the relapse setting and applied to relapse patients who were relapsed. We gave them a FLT3 inhibitor, put them in some form of remission, and the ones who had a deeper remission had a better survival. Now, looking back, we have the RATIFY study, 7+3 plus midostaurin. And we noted back then that patients on that study were transplanted in first remission who had gotten placebo didn't survive as well as patients who were transplanted who had gotten midostaurin. The same concept of they must be in a deeper remission. But we couldn't prove that with this study. But fast forward to today, where we have the Quantum First trial, chemotherapy plus quizartinib or placebo, we have this MRD assay, and we can say, look, the patients who underwent transplant on the placebo arm didn't survive as well as the patients who underwent transplant on the quizartinib arm, a deeper remission, which we can actually literally see in patients on that trial. And you can see there's a wide range. Each dot is a patient's MRD VAF. There were more negative MRDs in the quizartinib arm and a threefold lower just after one cycle of treatment. So to summarize the problem, we have different patients, different versions of the disease. We've got a lot of tools now. We have imagination and desperation. We're all good at that. So I just want to touch on some findings from a recent trial. This is MORPHO, a randomized trial of gilteritinib, a FLT3 inhibitor administered versus placebo for patients with FLT3-ITD AML after transplant. Global study, primary endpoint was relapse-free survival, but we very much focused on MRD. In this trial, using that assay I just described, we collected a very high level of quality samples, first pull, from these patients pre and post transplant, before they were randomized to get the drug. So we have samples before and after their conditioning. And before conditioning, we found 46% had detectable MRD. Immediately after conditioning, there was around 20%. And in fact, when you kind of add them all up, it's around half of the patients had peri-transplant MRD. And the primary endpoint was negative, meaning the relapse-free survival was with gilteritinib was not statistically significantly better than placebo, although you can see we missed the cutoff by one or two patients. But in fact, the really premise of the trial was to demonstrate MRD, and you can see that patients with MRD positive disease clearly benefited from gilteritinib, whereas those who were MRD negative in the peri-transplant period did not. And under no circumstances can you find MRD negative patients benefiting from the FLT3 inhibitor, under no circumstances. So if you go to transplant and you're MRD negative in the peri-transplant period, there's no reason to give a FLT3 inhibitor of any kind after the transplant. And you don't want to give a FLT3 inhibitor to everybody, particularly the patients who don't need it. We did see toxicity with this trial. We saw emergence of chronic GVHD and treatment-related infections. There was myelosuppression. In fact, shown here, the most common toxicity was myelosuppression. The drug, though, is effective regardless if you're pre or post transplant MRD positive. And it is remarkably quantitative. I don't know of any MRD assay that can do this. Perhaps our CLL colleagues can come up with this. But look at the degree of quantification of this assay. No MRD is better than a little MRD, a little bit more, or the highest level. Literally a ladder in terms of relapse-free survival and relapse risk. So it's quite quantitatively associated with clinical outcome. And there's no safe level. Any level detected in this disease has the potential to relapse. And at every level that we can look, gilteritinib helps prevent relapse compared to placebo. So a threshold or a level of sensitivity to me makes no sense as a leukemia doctor. If I can detect the ITD that the patient was diagnosed with at a low level at some point in follow-up, that's the disease. Remember, the FLT3 mutation is the final mutation usually in the sequence of development of AML. If you're detecting their ITD, you're probably detecting disease. And in fact, I can kind of demonstrate that here. These are looking at 71 patients on this study who had MRD after their transplant. They've already engrafted. Everything's ready to go. They're about to go on gilteritinib or placebo, and they have detectable MRD. So we actually looked at the kinetics of relapse for these patients. Everything was happening in the first 6 months in the majority of patients. And I'm kind of blowing this up here for you. Each line is a clone or a patient, either relapsing or eradicating the clone. And you can see on the placebo arm, there's an allogeneic effect that's eradicating a significant number of clones. But you can also see patients clear down here, barely at the level of detectability, if you will, at levels of 1 or 2 times 10 to the minus 6, that rise, relapse, and kill the patient. So disregarding some level below 10, calling 10 to the minus 4 as our cutoff, this makes no sense to me as a clinician. I get it. I understand people want to do that to look at broad numbers, make broad conclusions. But for the patient in the room in front of you, if they have a detectable clone at these levels, they have the potential to relapse. They have less of a potential. Totally agree. However, placebo, the allogeneic effect was really unable to eradicate some of these high levels. Almost none of these were eradicated. They relapsed. Whereas, interestingly, with gilteritinib, patients who had very high levels could still be eradicated. So gilteritinib was clearly exerting an effect here. But here's a fairly terrifying case to look at. The patient on the study has their transplant right here. You can see 3 different clones, and here we're getting into this multi-clonal disease. 3 different clones at pre-transplant. After the transplant, we can still detect 1. These 2 are below the limit of detectability. And so per protocol, the patient starts on gilteritinib. This patient was on the gilteritinib arm. The patient's blinded. The physician is blinded to MRD and to the drug. No one knows what's going on. We're looking at this in retrospect. So the gilteritinib is started. You can see the red clone here, the 30 base pair, which, by the way, was the original diagnostic clone, rises steadily. So the shark is still there. No one's aware of it. The patient's in a complete remission. Counts are normal. And we know that the patient was on a therapeutic level of drug. We have pharmacokinetics. Per protocol, it's 2 years. It's time to stop the drug. So, of course, patient relapses rather promptly. Shark makes it to the surface. Now, about this multiple ITD. every study that has looked at this using this method, amplicon-based PCR followed by NGS, has seen these multiple ITDs. What do they mean? None of them have really had enough numbers to tell until now, I think. So here's some examples of some of these earlier studies. Here's a case where there were 6 different ITDs in remission. This was the one that actually emerged and killed the patient. This was the GET ITD study, where again, they noted multiple additional ITDs not detected by the conventional PCR. Here's a study out of, I believe, in fact, it was China, that looked at multiple different clones and how they behaved. There's a way of looking at these multiple signaling mutations in this disease, and the evolutionary biologists perhaps have told us. The concept is all these different clones are arising in parallel and competing with each other, interfering with each other. And so the concept is called clonal interference. The most chemo-resistant might actually be at a low level at presentation, and you clear out, but it was being interfered with by other clones. It couldn't expand. You give chemotherapy, and now it can emerge. The French cooperative group Philo looked at this in core binding factor, examining FLT3 and KIT mutations in core binding factor, and noting that patients with multiple mutations clearly did worse. So here is out of the Morpho study, these multiple mutations. First, anybody with multiple mutations does worse than patients without multiple mutations. Remember, everybody has an ITD mutation, but the ones with multiple mutations have worse survival. But of course, that also means that they have MRD. If you look over here, the patients with no MRD, MRD single clone, MRD multi-clone have a difference, although it doesn't quite reach significance. But now let's look down here. First, at the placebo arm, you can see that patients with no MRD do well. Patients with either form, single or multi-clonal on placebo, they both do worse. Gilteritinib can bring the single clone up to the level of no MRD. So gilteritinib is effective against single clone disease, but not against multi-clonal. Just like that case I showed you. Slows it down, but doesn't eradicate it. So here's a few cases to finish off. This is this is how I'm managing the disease right now. 59-year-old woman shows up with a typical presentation with an ITD. And what I'm showing you here in the red line is her FLT3 ITD VAF. So at diagnosis, she got what we're currently using at my institution, gemtuzumab, single dose, 7 and 3, and quizartinib. Rapid reduction to undetectability in this assay, quite striking. And she got a round of consolidation, and it still is my practice to perform allogeneic transplant. All I could find was a 9 out of 10 unrelated donor, and she was MRD negative pre. We checked her chimerism day 100 post. She was MRD negative post. I do not have to use a FLT3 inhibitor, which is a good thing because she showed up with graft versus host disease, and I would have had a terrible time managing that, I can tell you, by trying to add a FLT3 inhibitor in this setting. So she's doing well. That's an easy case. And remember, you don't have to use the drug if they're MRD negative. And what is this business of graft versus host? Well, we've known that FLT3 inhibition or FLT3 stimulation increases dendritic cells, which in turn increases regular Tregs, and that inhibits GVH. So the opposite happens when you inhibit FLT3. Decrease dendritic cells, decrease Tregs, triggering GVH. And you will see this with some FLT3 inhibitors administered right after transplant. You'll cause a flare of graft versus host disease. All right, here's a 75-year-old woman, FLT3 AML, and I'm supposed to, according to some, treat her with a triplet, AZA, VEN, and GILT. It has a very high response rate in some of these studies. The problem is I also participated in this study of VEN and GILT in the relapse setting, and we found that most of the responses were basically an empty bone marrow. It was very aplastic inducing. It was sort of nuclear therapy, and since this was supposed to be for older patients, I didn't really understand that. And we know why. FLT3 is expressed here at the multipotent progenitor cell in normal hematopoiesis. The green is all where FLT3 is expressed at wild type FLT3. This cell is responsible for regenerating the marrow after chemotherapy. So if you, and it is, its survival is dependent upon BCL2 and FLT3 via an MCL1. If you inhibit BCL2 and you inhibit FLT3, you prevent this cell from reconstituting the marrow. So this is the combination of Ven and guilt would be expected to cause this kind of aplasia. I think of this disease a little differently. In the newly diagnosed setting, patients, these were blasts that we were putting in culture and treating with FLT3 inhibitors. Newly diagnosed FLT3 ITD AML is not FLT3 addicted. You can't kill it with a good FLT3 inhibitor. Relapsed FLT3 ITD, you can kill. And the concept is this: patients present with polyclonal disease. Many of these clones are not FLT3 addicted. At relapse, this is the clone that's FLT3 addicted. This is what you're trying to prevent with your FLT3 inhibitor, which is also why we see this phenomenon here. AZA-VEN patients, they'll go into remission, but they relapse very quickly with emergence of that clone. And in fact, you would predict this trial, which was a FLT3 inhibitor plus azacitidine, would fail. It's at diagnosis. Most of the patients have disease that's not FLT3 addicted. And effectively, you're treating them with azacitidine, which is terrible therapy. In fact, a branch of this trial, an arm of this trial, had patients just on gilteritinib alone. They had to close it down because only a fraction of the patients responded, which is what you'd expect in newly diagnosed disease. I also don't think it's easy to combine two CYP3A4 metabolized drugs. There's huge interpatient variability. So I don't think I don't think changing the dose or giving it less is going to work well. I prefer sequencing, as I'll show you. We studied gilteritinib in combination with cytarabine. It's perfectly safe to give. So back to my 75-year-old patient. Here's her VAF. Gets AZA-VEN induction. I don't drop her level very much. She's down at 1%. She got intermediate dose Ara-C plus gilteritinib. I've dropped her several logs just with that. I keep her on gilteritinib maintenance. Now I'm going to transplant her because I'll transplant a 75-year-old with reduced intensity conditioning. She's MRD positive pre, and I will start. I start the gilteritinib before I stop my tacro because I don't want to trigger GVH. Day 99, she's 100% donor chimerism. There's no MRD, and she's on gilteritinib maintenance. And we know, in her case, I want 2 years of maintenance. So she's doing quite well, live and disease-free. Here's a 19-year-old with 821 disease, core binding factor, with a FLT3 ITD. Is this good or bad? Well, we looked at this globally, and it turns out it's not good. FLT3 ITD in a core binding factor turns out to be intermediate at best. She didn't like hearing that. She's a 19-year-old engineering student at Johns Hopkins. So here's her VAF. We gave her GO 7-3 midostaurin, and here she's in remission. Her 821, the RUNX1, RUNX1T1 transcript is negative, but I can still detect the FLT3 ITD right there. And I'm nervous about this patient because she got HiDAC guilt maintenance, and at this point, she's MRD negative for both markers, and I do stop the guilt. And now I'm watching her. Still alive and disease-free with these two markers. Here's a patient who came to me after he'd already been put in remission for a transplant. We said, okay, we'll transplant him. I heard he had a 57 base pair ITD. It was a low VAF. Well, we transplanted him, and I started him on gilteritinib and checked his MRD. Oh no, I can detect it. What do I do? He didn't have any GVH. So I gave him DLI. All I got out of that was a fungal infection. Oops. So so I had to stop his gilteritinib while we treated his fungal infection. His MRD promptly came back up. Okay, what do I do now? Let's put him back on gilteritinib. Then we're in COVID. He gets COVID pneumonia, he gets RSV pneumonia. I had to stop his gilteritinib. This thing came right back. So now I just saw him the other day, and he says, "What are we going to do?" He's on gilt again. I have no idea. I'm thinking of transplanting him again. We're actually looking at it. I'm going to start following to see if this thing is rising. Finally, I'll share with you a fairly horrifying case again. Patient, 49 years old, 7 and 3 midostaurin. The VAF is dropped, but when I check the MRD, there's 3 clones there. That's bad news. He gets 1 round of consolidation, and I still can detect yet another clone. I transplant her, and she has disease post-transplant, polyclonal. Starts the gilteritinib, and you can see this thing rising. What do I do? Right, try the DLI. No, that didn't work, it rose. Let's try azaven, the triplet, that always works. No, that didn't work. It made her very aplastic. She actually got quite sick on that. Tried another round of DLI, that didn't work. I know, let's increase the gilteritinib to 200 milligrams. No, that won't work. Let's try quizartinib, it's more effective. Oh no, that didn't work either. She relapsed. In front of me. You'll note the time is 2 years. You have plenty of time with this assay. I haven't yet figured out what to do with these patients. So, for the management of this disease, there's no single approach. We have a lot of tools, though. We have intensive and non-intensive induction. We have multiple FLT3 inhibitors. We have a much more precise method of tracking the disease. We have allogeneic transplant even for these older patients. MRD can be used to guide the length of therapy and whether you need it or not. These multiclonal ITD mutations, I think, represent a high-risk subgroup. Stop there and open it up for questions.
Yeah, I think we invite Prof. Levis to come to the table, and also our panel members. Dr. Yvonne Loh from QV Oncology and Mount Elizabeth, Dr. Jay Surya. And is there Dr. Liu Ting around? Dr. Liu Ting, yes, please come up to the stage. And also we have Professor Andrew Wei, who's attending this virtually, and he'll be giving his inputs. So you can input your question on the QR code, and it'll be flashed here, and then we will pick the questions to take for discussion.
I think first I would like to invite Professor Andrew Wei to share your expertise because you are also one of the experts in freeze MRD detection. Andrew, please.
Hello, Mark. Can you hear me?
Yes.
Sorry, I couldn't be there. My daughter's doing her final year exams, and my wife said if I go, then I may not be able to come back. So I'm here. But thanks for a great talk. And I just wanted to comment on your survival curves at Hopkins with the triple mutant combination of normally death, where they're doing so well with the DNMT3A, NPM1, and FLT3-ITD combination. And I just want to ask, were those patients, some of those must have been getting presumably midostaurin-based therapy up front. My hypothesis would be that their MRD pre-transplant must have been fairly high. I know you like to transplant anyone that can move, and I presume you must have been using some post-transplant maintenance as well, but how did you get such good outcomes in that group when so many publications have reported so much doom?
Can you hear me? Oh, yes, here we go. So yes, the majority of those patients got midostaurin because we only started using quizartinib pretty recently. A substantial, interestingly, not all of them were transplanted, but they all are pretty heavily exposed to gilteritinib, either after their induction and maintenance or after their transplant. So some of those were aza-ven induction that then went on some form of gilteritinib maintenance. About 2/3 went to allo transplant, all of them mini. And that actually is another point that we're going to, I think, publish soon, is that the NPM1 mutated FLT3 ITD generates a clone that's exquisitely sensitive to FLT3 inhibition. And so you don't want chemo. And in fact, myeloablation makes this worse. You want reduced intensity because you want to get your FLT3 inhibitor on fast. I suspect there's more to it even than that. I was startled to see how well they were doing, but our approach has always been very uniform. We do follow MRD in all of those patients, and in most of them, in fact, in all of them, you can detect MRD after induction 1, correct. Half of them go negative after consolidation. And we didn't, the data out of Morpho, as you know, emerged in the last year or so, and so many of those patients were not, were all going on gilteritinib maintenance, although I'm changing that now. If they're MRD negative, they're not going on maintenance. And I clearly think we're going to see a change in MRD with the quizartinib. It does appear to be more potent, result in a deeper remission, and I suspect I'm going to be using less gilteritinib post-transplant. The real question is, how many of those now need transplant?
And if I could just ask a second question in terms of the general strategy. So most people are still using intensive chemotherapy plus midostaurin outside of the US and outside of clinical trials. But you said also that using a FLT3 inhibitor in the frontline setting was less effective because of multiclonality and less dependence on FLT3. So what do you think is the best strategy? Is it to start with a dirty kinase like midostaurin and then switch to gilteritinib if the patients are MRD, either at the pre or post-transplant stage, and the same with Ven/Aza? Or go to a more potent FLT3 inhibitor, like you said, with quizartinib, because I think, I guess some of the statements you've made are sort of internally not consistent.
So the issue of whether or not the disease is FLT3 addicted at presentation is really pertinent to the concept of using a potent FLT3 inhibitor by itself. I think the role of the FLT3 inhibitor at diagnosis is to complement the chemotherapy and to prevent outgrowth of the clone, not to help eradicate the bulk of the disease. So let's be clear on that. However, the choice of FLT3 inhibitor is still tricky because I don't think the dirty concept matters so much. I don't think it's important to use a dirty drug, and as you say, midostaurin. I think the key with midostaurin is it's less potent. And you might say that's a bad thing. I don't know that that's a bad thing because of the myelosuppression that you're spared when you use midostaurin compared to quizartinib. When we add gilteritinib or quizartinib to 7 and 3, the aplasia is longer, and we all saw the increased early deaths in the quizartinib arm of the Quantum First trial. So I'm by no means thinking that midostaurin is not as good a choice or isn't the better choice for the first cycle. But I think MRD will guide us in that, because I am struck by what I'm seeing with the addition of quizartinib. And the other thing I guess I would caution, and you know I'm a fan of sequencing, I don't understand what the rush is. Everybody wants to get the single best remission using the most thunderous induction they can come up with when the patient is sick, has infections, has a poor performance status. And I was struck by just give them aza-ven without a FLT3 inhibitor. It pops them into remission. They stand up. They're fully dressed and combed and ready to go. And then you can scale up the treatment. The question is with what? And that, I think, there's still a lot of work to be done in that regards.
Thanks, Mark. And I'll just ask a very brief question. I'll hand back to the panel. With the continuous monitoring with FLT3, ITD, PCR, and GS, we're now starting to see patients who are, I guess, breaking through gilteritinib maintenance with a rising FLT3 MRD, and we're a bit lost, as I suspect you might be, in terms of what to do next. Is it combining the gilteritinib with then switching to a more more modern, newer generation FLT3 inhibitor, or going back to using chemotherapy? And we're starting to see more WT1 mutations come through as well. It's, I guess we've, in some patients, replaced one problem with another.
Prof, is this for the panel or is this for Prof Mark?
For anyone who's got an answer to gilteritinib resistance.
Literally, there's a patient that emailed me this morning that I'm panicked is going to be exactly what I just showed you. She had a rising clone, both NPM1 and ITD, and she had multiclonal disease. At the present time, I'm giving her the triplet, but I'm under no illusions that that's going to buy me much time or do anything more than give me toxicity. I'm actually planning a second transplant for her. Which I'm not happy about, but I don't. She has chronic GVHD. I haven't been able to get her on a higher dose of gilteritinib than 80 without making her mouth fall off, and the GVHD is not working. And again, it's this multiclonal disease that is something biologically different about this.
Just may I ask, so what do you think about as Prof. Andrew Wei alluded to, the more novel agents or even things outside of FLT3 inhibition, for example, menin inhibitors?
So I think that, everybody is studying menin inhibitors, and these drugs really work well. The remissions you get on menin inhibitors are real ones, not these pseudo ones that you get on a FLT3 inhibitor. Unfortunately, they're not approved yet. I can't give it to my patient here, but I think actually she has an NPM1. That would be what I would go after. And so, all this DLI and second transplant and aza-ven stuff may just go by the wayside, and we can add, a menin inhibitor. I don't know. We'll find out.
Does the other panelists have any comments?
Just asking about your patients who are on the FLT3 inhibitor, gilteritinib, and they develop GVHD. Do you actually interrupt the treatment, and have you ever had to use Jakavi together with your gilteritinib to treat the GVHD?
So, first of all, I always know their MRD status. And for example, if they were MRD positive pre-transplant, MRD negative post, and they are simply on gilteritinib maintenance because we showed that they benefit, that's a patient who, if I have trouble with their GVH, absolutely I might be stopping it. In some cases, I stop it well before the 2 years. I've definitely done that. As long as they've had maybe 6 or 8 months, and I finally throw in the towel and say, I give up. I can't control your GVH on gilteritinib. I check their MRD one last time, make sure it's negative, and stop. That has worked. So thus far, knock on wood, the MRD assay has not failed me. I've never had the patient relapse with the ITD clone when I've confirmed that it's negative. And this is the importance, though, of the sensitivity of the assay and the amount of material you feed into it. There's a recent publication, again, out of the German group, using only 50 nanograms. And they noted there's no time to respond because they're picking up the clone at 10 to the minus 4, whereas if you feed in 10 times the amount of DNA, you're going to get your reading at 10 to the minus 5. And you saw how much time you have on these patients. You have plenty of time. You have months. This clone rises slowly. So I'm following a number of patients like that. I've got all these older patients who weren't transplanted with clones at 10 to the -5, and I'm nervously watching them. They have to stay on their drug, and some of them have been on the drug for years. I think this assay, mind you, I hope it gets obsolete in a few years with better ones that we're developing. But right now, this really opens up things for the field, I think.
I have a question for Mark and the panels. I think due to the financial toxicity or financial issue, the more powerful next generation fusion inhibitor is not available in Asia Pacific country. Did you comment the sorafenib? Because the data in mainland China demonstrate the clinical relevance of sorafenib in pre and post transplant setting.
Well, I used sorafenib for many, many years and had no choice. I hated the drug. The patients hated the drug, but it worked. In fact, the reason I still point to a patient that I had on sorafenib, he was on one of our trials. He had been on sorafenib for 3 years, was on painkillers because of the neuropathy and horrible gastrointestinal symptoms, but he was in remission. And after 3 years, we said, okay, let's stop it finally. This should be enough. And he relapsed and died within the year with the exact same FLT3 mutation. That patient in 2012 was the patient I remember, okay, we need an MRD assay. You don't have any choice. If you don't have an assay like this, you're obliged to treat your patients with sorafenib, and you will make them suffer. And guaranteed, you are treating 2/3 of them who don't need the drug. You're harming 2/3 of your patients, guaranteed. I recognize the difficulties that you have, but this is why you should be aware that that's what you're doing. I mean, we did it for years. You have no choice. The drug works, but 2/3 of patients don't need it. And there it is. I mean, I wonder, it may be more than 2/3 with the use of 7 and 3 midostaurin. You might get better, deeper remissions with the midostaurin, and maybe even a smaller fraction needed. But there is no substitute for MRD. Otherwise, you are going to treat patients with sorafenib who don't need it.
Could I ask Dr. Liu for your comments about the sorafenib being used in China?
Okay, I think the AML with the FLT3 ITD mutation is very interesting thing. And as you talk, and maybe garetable is more, it's the best result and for FLT ITD inhibitor. But as we know, at market, we have sorafenib, irritainable, midostaurin. So my question is, which drugs can be used more common or more effect?
I would prefer sorafenib over midostaurin. Midostaurin, in my experience, and I think with lab data, is only effective for about 1 month. You then get upregulation of P450 enzymes and the drug level falls. Sorafenib is a very effective drug for inhibiting the target. And even though we don't like to use it, it is very effective. And you can, of course, as you, I'm sure, know, start the patient at a low dose, 200 twice a day, scale up to the highest dose you can get in the patient. The problem is patients still become non-compliant if they have to take a drug every day that they hate. So,
My second question is, as we know, FRT3 ITD it can became a key mutation or a driver mutation for drug treatment, such as that is such as because the patient accept the FRT3 ITD mutation, and they have many other mutation combination with their disease. So one good example is APL. As we know, APL the driver mutation is Pimirara, but the patient they have some FRTITD mutation. But we treat APL with reniticoside acid, get a very good result and can be cured of that. So FRTITD in that disease, I mean APL, maybe it's not more key roles. So my question is, in FRTITD disease, this mutation can become the driver mutation for drug treatment.
So that argument has been made ever since we've been studying FLT3. I completely agree that FLT3 is a late hit, and there's much more important ones earlier. Give me the drugs. No one has the drugs. No one has a drug for RAS. No one has a drug. The NPM1, I think, is going to make a big change. I think it will be effective in FLT3 mutant disease. It's the earlier hit. But if they don't have an NPM1, what do? You say target RAS. With what? We've been trying for many years. I think, and the problem with RAS, I think RAS is similar to FLT3. If you target FLT3, you get RAS mutation. If you target RAS mutation, you'll get a FLT3 mutation. You probably need to do earlier than that. But we don't have the drugs. We're just starting. So the argument you make is valid, but not practical. We have the patient in my clinic is dying of a FLT3 mutation, and I have a FLT3 inhibitor, so that's what I must use. And if it is sorafenib, that's what we use.
Maybe adding to his question, what if the patient has an IDH1 mutation and then a FLT3? Do you think in that instance you might consider targeting the IDH1 instead? And then for the last case that you presented, are you able to test whether there's some perhaps an emergence of a resistant clone that is resistant to gilteritinib, and that's perhaps the reason why it's continuing to rise?
So regarding the IDH mutant patients, I actually have 6 patients in my clinic who are on both ivosidenib and gilteritinib, same time.
Okay, sorry to cut in. Yeah. You guys only have like 5 minutes left, and I guess the topic of this is what tools do we have? So, Mark, we have transplant, we have Azavan, we have gilteritinib, and all the rest, but MRD is the key, as you demonstrate, is very useful. So maybe in the last 5 minutes, can I suggest to the chairs, ask the audience whether they have the MRD testing for FLT3, is it useful, and whether your working group wants to develop that, and then maybe with the working group, maybe you guys can discuss that. Maybe left, I think probably the key is MRD mutation. A lot of us do not have that because it's very complicated.
I think Andrew Wei might have the best comment on that.
Yes, yes. We have talked to Andrew before. So they all have their lab stuff, and then do you want to maybe do a survey to see who has MRD testing and where do they do? Maybe around the panel.
I think in Taiwan, PCR NGS is undergoing. At this moment, the FLT3 ITD sensitivity was only 0.1%. Yeah, not very sensitivity compared to be used in Western countries. But
for the MRD, the MRD with ampliclons and the MRD testing, MRD.
Yeah, MRD test. I mean the PCR NGS MRD platform is undergoing.
So Taiwan is doing that.
Yeah.
Zheng Tang, Singapore.
So we are developing our own NGS MRD, but currently we don't have it yet. So our surrogate is the PCR, which is not as good. And if there is the fusion transcript or the MPMN transcript, we use that as once again as a surrogate.
J, Malaysia.
No MRD assay.
No MRD. And China, Liu Ting? PCR but no MRD. What about Korea? Professor Kim? Prof. Kim, Korea? Same thing. So is there a need to standardize for the whole Asia Pac? Do you want to work together in a working group? Do you think there'll be a useful?
I mean, this all can be up for discussion.
Yeah. So maybe the working can focus on that. Just a humble suggestion.
Maybe we just have a few quick questions from the audience. We'll take Prof. Lizzo's questions. So, do you think 3+7 can be replaced by venetoclax azacitidine in certain groups of AML patients, even if they are young and fit?
Yes. The one group that we looked at that I think don't benefit from aza-ven that I can definitely say compared to 7 and 3 is core binding factor. Our patients who have core binding factor AML who got aza-ven clearly are not getting the same depth of remissions. We're seeing relapses not as good. But I think the statement AML is wrong. It's, well, what subtype of AML are you talking about? So I suspect FLT3 mutant AML might do better with aza-ven induction, to be honest. I think core binding factor will do worse with aza-ven induction, and I'm not sure about the other subtypes yet. And I think we should never be looking at the disease as one disease. It's always subtypes.
What do the rest of the panelists think?
I think more and more data suggests low intensity regimen could provide a higher response rate, especially in high risk AML such as MDS or NPM transform AML. So personally, if the patient has a high risk feature and transplant eligible, I would like to use a main-based treatment as a bridge to foresee transplantation.
Yeah, I think it's the same for me here. For secondary types AML with not a very aggressive disease, I tend to favor aza-ven as a bridge.
Yep, I agree. I think because we have good tools after that, especially for the FLT3 mutated AML.
I agree as well.
I agree.
I think we'll ask one last question. So I think I'll just make it a more whole question. So the question was, are there sequences with FLT3 mutations that correlates to drug resistance? I think the broader question is, if we talk about subgroups, are there subgroups of FLT3 AML that are less amenable to targeting by gilteritinib? For example, if it's a secondary type MDS AML with a FLT3, or and on top of that, does the type of resistant mutation they develop after that differ?
So in the very early, this was 20 years ago with the trials of quizartinib, I remember a patient who had MDS and developed a FLT3 clone that turned her into AML. And we treated her with quizartinib and completely eliminated the FLT3 IgD. Her marrow looked terrible afterwards. There was no benefit. All we did was eliminate the clone. As you've implied, MDS AML doesn't benefit that much, which is why, again, it's important. FLT3 mutant AML is not one thing. And I suspect the myeloproliferatives that I occasionally see that get treated with a FLT3 inhibitor, they don't really benefit. I'm not sure that APL would ever benefit from a FLT3 inhibitor, these later.
I feel sorry, even we have a lot of questions, and due to time limit, we have to close this session, and more discussion will be performed in coffee break. And thank you very much for Professor Mark and the panelists, and also Andrew Wei on the website. Thank you.
So I think the next up is the long-awaited coffee break. Yeah, I think there will be refreshments outside. So everyone, please adjourn to the lobby and for refreshments. And you can take all the questions you have also with Prof. Lewis later. Yeah.